Mritula Ramesh of second year MBBS, and I'll be continuing today. General principles of diagnosis of occupational skin diseases. Because of the prevalence of occupational exposures that can cause or exacerbate skin disorders, it is advisable to screen all patients with skin disease for a work related cause. If occupational skin disease is suspected, questions should be asked about the exact time relationship between the skin condition, that is, onset, improvement, and recurrence, and the work exposure, including the effects of time off and return to work. An in depth occupational history should cover the following points: general work conditions and specific activities in the patient's present job that involve skin contact with potential hazards. Material safety data sheets are more informative for large acute exposures than for the low level chronic exposures that are so common with skin conditions. Physical, chemical, and biologic agents to which the patient is or may be exposed, presence of skin diseases in fellow workers, control measures to minimize or prevent exposure in the workplace, including personal and occupational hygiene, and the availability of gloves, aprons, shields, and enclosures. Compensation the patient received for skin diseases in a previous job. Other exposures including soaps, detergents, household cleaning agents, materials used in hobbies, and topical medications, especially those containing sensitizing agents such as a neomycin. The physical should look for eczema, hives, asthma, hay fever, clothing or food allergy, psoriasis, acne, oily skin, prickly heat, contact allergies, fungal infections, family history, and systemic diseases that may have skin manifestations. The history of the illness and the occupational history may reveal a close association between the skin condition and a specific work exposure known to produce such skin effects. The appearance of the condition may also suggest the cause. For example, a glove pattern distribution of vesicular lesions on the hands strongly indicates a contact dermatitis. General principles of treatment. For therapeutic purposes, contact dermatitis can be classified as acute. Therapeutic measures can almost always provide some relief, but cure depends on the identification of the offending agent and cessation of exposure. Acute dermatitis. Wet dressings. Absorbent materials moistened with cool water or Boros solution should be applied to the affected area 4 to 6 times a day. The effect of this treatment include bacteriostasis, gentle debridement, debris removal, and evaporative cooling. Steroids. Topical steroids have no effect on acute vesicular reactions, but they may be applied once vesicles have resolved. Systemic steroid therapy is indicated when lesions are widespread, vesicular and edematous or bullous. Short course of prednisone in a dosage of 40 to 60 milligrams per day for 5 to 7 days are usually satisfactory and do not require tapering. Secondary infections should be treated. Systemic steroids should be used cautiously in patients with diabetes mellitus, psychotic disorders, uncontrolled hypertension, or infections such as tuberculosis or herpes. Systemic antihistamines. Diphenhydramine is in a dosage of 25 to 50 milligrams 3 or 4 times daily, or hydroxyzine hydrochloride in a dosage of 25 milligrams 3 or 4 times daily provides an antipruritic effect. Because of the sedating effects of these drugs, patients should be advised against operating machinery or vehicles. Doxepin in a dosage of 1 to 3 10 milligram capsules should be taken at night as needed, is effective, but patients should be monitored for anticholinergic effects. A 5% doxepin cream is also effective. Topical antihistamines should be avoided because of their potential sensitizing action. Chronic dermatitis. Emollients. Topical agents such as petrolatum provide an occlusive film over inflamed skin, decrease fissuring, and reduce evaporation. Emollients are most effective when they are applied after skin has been soaked or washed in water. Topical steroids. These agents reduce inflammation and associated pruritus. Topical steroids should be applied no more than twice a day. More frequent use provides no advantage and may induce tachyphylaxis. Treatment with higher potency fluorinated steroids such as 0.05% fluconamide is contrast to mid potency 0.1% fluoroquinolone acetonide, is indicated in patients with more persistent dermatitis or chronic dermatitis affecting the hands. Occlusion with plastic wrap or plastic glove enhance absorption. Fluorinated steroids should not be used around the eyes, on the face, or in the groin area because of the long-term effects, which include the development of striae. General principles of prevention and control. Most occupational skin diseases can be prevented. The following issues should be considered. Predisposing factors that contribute to work-related skin disease on a particular job. For example, fair skin would be a predisposing factor in construction work who is chronically exposed to sunlight. Avoidance of certain work environments by workers with pre-existing skin disease. For example, a hairdresser with chronic eczematous eruption of the hands might be advised to change professions. Workers should be counseled about personal hygiene, and management personnel should be advised about proper hand washing agents. Contact with organic solvents should be scrupulously avoided. The following should be recommended: provision of effective non-irritating, non-allergic skin cleansers, use of emollients, hand lotions and creams after hand washing, frequent clothing changes, daily showering, rapid removal of oil and chemical soaked clothing, use of company laundering facilities or separate washing of workers' clothing at home, and no eating, drinking or smoking in the work area. Replacement screening. A history of skin survey can be used to determine if a worker has a pre-existing condition that increases the likelihood of occupational skin diseases in the job under control.